Population suffers from medial epicondylitis or golfer's elbow, and this is basically irritation to the common flexor or pronator, flexor-pronator mass, right? So you're going to palpate the medial epicondyle in this case. This can also be positive in your throwers who have a UCL injury because that flexor-pronator mass sits directly on top of the UCL. These tests are exactly the opposite motions of the lateral epicondyle test. So the first one is you're going to have them elbow supported, but you're going to have them flex their wrist and hand. You're going to palpate the medial epicondyle and then say, don't let me pull you out of that. Right? So now we're resisting wrist flexion. And because we're resisting that, they have to activate those muscles, which then puts tension on the medial epicondyle. All right? The other one is going to be passive through that range. So instead of last time we had them pronated, this time we'll have them supinated. We're going to extend the elbow and then pull the fingers down towards the floor. So their flexors get put on stretch, which puts tension on the medial epicondyle. So go over those two really quickly because, like I mentioned in the lecture, the elbow, it's a very intricate joint. It's very small. So if there's any swelling in that joint, that swelling is going to compress structures. And not only you'll feel tightness from that increased swelling, but it might push and impinge on a nerve, which will give you those weird sensory feelings, right? Numbness and tingling and pins and needles and things like that. You might also have numbness, or I said numbness, sorry, but you might have like heaviness in the hand too. So the first one I want to go over is called Tinel's sign. And essentially Tinel's sign is just a tapping of a nerve to see if it reproduces our symptoms. Because it's already irritated and you tap it, it will make it a little worse. So you're going to grab the patient and just find their cubital tunnel, so in between the olecranon and the medial epicondyle. First, I would just palpate it so you're in the right spot, right? And then I would provide a tap right into that area. This is your funny bone, right? So the people you're examining might even feel this run down into their pinky and ring finger, right? As you tap. So try that one too. Grab your partner's elbow and tap. This is called Tinel's sign, Tinels syndrome. So the median nerve runs right through the middle of the pronator teres. And sometimes if you have an issue with that pronator teres, that will spasm, become tight, and then pinch your median nerve and give you symptoms down the chain. So all you're going to do, you're going to have them in an elbow flex position. Okay? You're going to put them into neutral grip first. I want you to try use your thumb and push deep into like the brachioradialis because the pronator teres sits underneath that, deep to that. So you're going to try to push into that area, provide some compression, and they're going to resist elbow flexion and pronation. So you're going to try to extend and supinate their hands. So grab my wrist, but I'm pushing here. I'm trying to extend you and supinate you. You don't let me do it. Good. And then they'll find they get their median nerve distribution, middle finger, index finger, reproduces some of that issue. Okay. Syndrome. So the median nerve runs right through the middle of the pronator teres. And sometimes if you have an issue with that pronator teres, that will spasm, become tight, and then pinch your median nerve and give you symptoms down the chain. So all you're going to do, you're going to have them in an elbow flex position. Okay? You're going to put them into neutral grip first. I want you to try use your thumb and push deep into like the brachioradialis because the pronator teres sits underneath that, deep to that. So you're going to try to push into that area, provide some compression, and they're going to resist elbow flexion and pronation. So you're going to try to extend and supinate their hands. So grab my wrist, but I'm pushing here. I'm trying to extend you and supinate you. You don't let me do it. Good. And then they'll find they get their median nerve distribution, middle finger, index finger, reproduces some of that issue. Okay. Our distal tendon insertions. So we're going to look at distal biceps tendon as well as distal triceps tendon insertion. And what you'll commonly see if they have anterior elbow pain and they have bruising and swelling and very swollen area, and if they also have what's called a Popeye deformity, which is where this bicep rolls up and kind of makes a little ball right here, that means the distal tricep or distal biceps tendon has ruptured and there's no insertion anymore, so it's rolled up on you because it has nothing to be attached on. So where you get into trouble with this, all the test is you're going to resist some bicep brachii, manual muscle test essentially. Now you have to be careful here. You can palpate like the tendon to make sure it's there, right? So if you feel and if nothing's there, and they have this Popeye deformity, pretty obvious diagnosis, right? But during my residency, one of us residents, somebody had pain in the anterior or antecubital fossa. They went and did this to check for it. This thing snapped and rolled up on them right there. So you just got to be careful, because if they have a partial tear and you provide pressure, you can make it a complete tear. Yeah.
True story.
So, yeah, and look, this is something they don't necessarily need to have surgery on. You have to think about what the patient's goals in life is. I've never really seen, I guess I've kind of seen a Popeye deformity in the back, but it doesn't roll up as much, and I think that's just due to connective tissue and how the tricep sits on the humerus. But what you can feel is feel for that distal triceps tendon. If it's very tender there, you're suspecting that. You can resist elbow extension, right? So don't let me push you up. If it reproduces their pain at that distal insertion, you're thinking that. And then also with both of these, you can test some passive insufficiency as well. So if you lay on your back here, if they become apprehensive or painful when I take her over and bend here and then lift up, right? We're putting a lot of tension on that spot, so she might feel some pain. And then if you scoot to the edge of the table here, same thing with the biceps. You'd supinate, drop their arm off the table, keep them in a supinate position, put stress on that tendon there so we stretch it out. Does that make sense? You guys want to try that?